dependence. Patty?
Thanks. Good morning, everyone. Thanks for having me today. So we're going to focus on communicating with patients about their tobacco dependence, and it is really important that everybody be prepared. So in order to ensure a patient's success in their quit attempts, we want to make sure that they are prepared, but we also want to be prepared in our teaching and talking to them as well. So who should be talking to patients? Well, basically all of us should. So physicians, physician assistants, nurse practitioner, nurses, dentists, mental health professors, and everyone else in between, we should all be talking to patients. We're all a part of their team, no matter what our specialty is. It's important that we all engage and talk to patients about this issue. So in the guidelines that Dr. Novak alluded to just a little bit ago, they outline these kind of 5 A's, and this is a process to kind of help you through addressing these issues with your patients. There is abbreviated versions of this. There is something called the 3 A's, where it's just kind of cut down to ask, assess, or ask, advise, and act. So basically a longer version of that, and we're going to kind of focus on each one as we go. So asking the patient. So what can you do? So a huge amount of patients want to quit, and that's been very well documented in the literature. It's really important to start the conversation and ask, because if nobody asks, they aren't inclined to usually. So it's really important to try to help our patients to bring it up and get the conversation started. So I'm not going to go through this just for sake of time, but this is also a part of that guideline that I just discussed that kind of helps guide you through the process of, you know, if the patient says, yes, I use tobacco, no, I don't want to quit, or no, I don't use tobacco, but I quit, and, you know, making sure you're supporting them throughout. So a part of most of our electronic records nowadays do address this kind of status, and it's important to note that tobacco status is not equal to smoking status. So although we are going to focus mostly on tobacco smoking, cigarettes today, there is a lot of other kinds of tobacco out there. So it's really important that you be very upfront, because if you ask the patient a very closed-ended question like, do you smoke cigarettes? Their answer may be no. So you want to make sure you address any and other kinds of potential tobacco use, such as electronic cigarettes, vaping, chewing tobacco, cigars and mini cigars. There's a lot of cultural different products that patients can utilize depending on their cultural background. So I work with one of the refugee organizations here in Rochester, and a lot of their issues surrounded by very specific regional tobacco products that they utilize. So it's about focusing and helping the patient to realize that not just smoking is dangerous, many other tobacco products are also dangerous. It's important to use a non-judgmental approach, because if you come at the patient with a kind of judgy tone, they may just shut right down and not even tell you the real kind of status of where they're at. So think of kind of some ways you're going to approach patients when they're coming in for visits. Instead of saying really close-ended, kind of judgy remarks like, have you quit smoking yet? Why haven't you quit yet? Why are you still smoking? Think of things that are more open-ended and less judgy, like, tell me how things are going with your smoking. Have you thought about quitting recently? What do you like about smoking? What do you not like about smoking? Like, how much do you want to quit right now? Because these things can really show your interest and concern while avoiding the kind of closed-ended judgmental questions that could close everything off. So for advising, we should all advise all smokers and or tobacco users to quit. Ensure them that we can help. So it really can take many, many times to be successful in the long run. And like the law commercials on TV, past results do not guarantee future outcomes. So just because you haven't succeeded in the past doesn't mean you're not going to succeed in the future. We should always be very non-confrontational and encouraging as much as possible. So think about reframing things, kind of in alignment with what Dr. Novak said just earlier. There are a lot of interactions that happen with medication. So in my specialty, I work with cancer patients who are undergoing treatment. And we know that cigarette smoke can interact with chemotherapy and render it less effective, as well as radiation. Can also affect surgical outcomes, increasing risk of infection, blood clots, and reduced healing. So part of my approach is not to say, well, you already have cancer, so you should quit smoking. It's, you know, we want your cancer treatment to work the best it can. So if you're able to stop smoking, your, you know, chances of getting the best kind of outcomes from your chemo is really important. So avoiding negative and accusatory undertones, which can really undermine the patient's motivation to move forward. So I'm not going to go through this in a lot of detail, but these are kind of the stages of change. So it's important for you to kind of quick figure out where the patient is in this process. Are they thinking about quitting? Are they not interested at all? Or they have already quit and they've been smoke-free? It's important for us to still intervene no matter what their phase is in the stages of change. So this is a busy slide also, but it kind of comes down to the nitty-gritty parts. Is self-determination theory is a theory of change and distinguishes between autonomous and controlled motivation to change. So our goal is to help patients to support their autonomy and offer choices, acknowledge their feelings, and minimize control so that they are on the kind of right side of the line there. So anybody on this right side is more likely to engage and sustain in their behavior change. If they feel like they are coming to see me because their oncologist told them they should quit and they have no interest in quitting, then their success may not be as great as someone who is really interested in helping improve their health. So our goal is here is to keep the patient engaged and keep them so that they're in control. We utilize motivational interviewing in our program, and this is a patient-centered counseling where we, again, promote autonomy. We explore their ambivalence and their worries and their fears, and we use a lot of open-ended questions to keep the patient engaged. We stay as non-judgmental as possible and try to reflect what the patient is saying back to them so that they can kind of continue to move forward in their journey. Motivational interviewing and self-determination theory go quite nicely together. So this slide shows the relationship between the two. So we should always, you know, kind of keep the two in mind when we're working with patients. So motivation is a fire from within. If someone else tries to light that fire under you, chances are it will burn very briefly. So this is kind of speaks a little bit to the autonomy and how important autonomy is. So if someone tells you you have to quit smoking and you quit, you may not maintain as long as you'd like. So some questions to consider when you're talking to patients, questions that help you move forward in your treatment and recommendations of the patient. So asking the patient openly, what are your goals? What is your hopes to come out of this? Do you want to quit? Do you want to cut down? Do you just want to kind of find out what's out there and what we could do in the future? And then asking kind of the real details. How old were you when you started smoking? How many cigarettes are you smoking per day over the last month? What's the most you've ever smoked on a regular basis? How long after you wake up is your first puff? And what's the longest you've ever gone without a cigarette? So that is one of the key questions that I try to ask patients, and I try to avoid that kind of, have you ever quit before? Because that can be a little bit more accusatory, and if patients have never quit before, they may feel more embarrassed. So keeping it open. A lot of these questions speak volumes to the patient's addiction to nicotine and can help you kind of keep your mind moving forward in what you're going to recommend medication-wise as well. So some real life situations. I ask patients, what do you like about smoking? And a lot of times people just kind of, the top answer I get is it helps me relax, or it's my escape and gives me some me time. But when I say, what do you not like about it? I often get a list as long as this list. It's really quite significant. So what I do is when we're done talking about this, I kind of point out, look how easy it was for you to point out all these things you hate. but you like one thing about it. So people aren't usually inclined to think about these kinds of questions, and sometimes, especially the what do you like about smoking, takes them a long time to even think about an answer. So that's a really telling question to ask patients. Sometimes patients will say, I've tried a million times, I just can't do it. And I find that this is just one of the many kind of resistance that we get when we're talking to patients about quitting. So it's about kind of rolling with the resistance and thinking of a way to kind of counteract it without being, you know, judgmental or bossy. So if someone tells me they've tried a million times, I try to just kind of reiterate, it can take a long, long time to quit smoking. This is something that's been in your life since you were 11 years old. It's not realistic that you can just stop overnight. It can also take many quit attempts before people are actually successful. And sometimes our first plans don't work out and it takes help. And really that's the biggest thing I try to promote, is that we're here to help. Because if patients have not been successful when they quit on their own, having help can significantly increase their chances of being successful. So a lot of things I hear, and of course I work in the cancer center, so people have insurmountable amounts of stress. It's not a good time. I have a lot of stress in my life. I want to wait till my stress is better before I quit. But that's really not a realistic thing, because we're always all going to have stress no matter what. So it's about helping them try to manage their stress levels at a reasonable level so they don't feel that that's a barrier for them. A lot of patients will say, my spouse smokes and he doesn't want to quit or she doesn't want to quit, so I can't quit. So I encourage patients to have a conversation with their spouse to say, hey, I want to quit. If you don't want to, that's okay, but I really would like your support. So please don't offer me any. Please don't leave yours sitting out on the counter, and just try to help me through this because it's really important to me. And generally, people are really supportive. I just tell patients, you know, I don't want you to go home and tell your husband, you have to quit because I am, because that's just not going to be a healthy conversation for them to have. Control is always a big issue too. People, especially in my clinic, you know, they feel like their whole life is kind of spiraling and they're no control. They're coming in for chemo and radiation and they're kind of living their life by the cancer center. So they feel like this is the only thing they have left to control. So I often try to flip the script a little and say, you know, consider the control that these cigarettes have over you. They're financially controlling, emotionally and physically controlling. So we try to kind of turn it around so that the cigarettes are really the bad guy. So it's important, if the patient is really wanting to quit, that you can help them. Assisting them is multifactorial, includes behavioral changes and counseling in addition to the pharmacological, which is also an important part. So I often ask patients, like, what are your triggers? I'll ask them that in our first visit, but also as we move forward, because sometimes they can't identify these triggers until they're in the middle of their quit plan. And then they say, man, I can't drive the car because I got to have something in my hand. So we discuss things they can do, you know, not keeping the cigarettes where you can reach them, or having some lollipops or something in the car, or your nicotine, you know, supplement. So it's about teasing those little things out. A lot of responses I get are, I've tried everything. I've taken every single medicine and none of them work. So I will go through what they've tried before. I will say, hey, did you know there are 7 medicines that can help people quit smoking? And they're like, oh, I didn't know that there was nasal spray or inhaler for nicotine, or I didn't know about Chantix. So like Dr. Novak alluded to earlier, it's really important to explore their previous experience with medication as well. So if they've used the patch before, maybe they were underdosed. If they utilized varenicline and got really nauseous with it, they didn't know they were supposed to take it after food. Or they got nauseated with the gum because they didn't know chew and park. They just bought a pack of gum and thought, I'd chew this like gum. And that's definitely not how we want them to do that. So it's about educating and also techniques. So I sometimes will have people bring in their medication with them, especially the inhaler and nasal spray, and I'll have them use it right in clinic just to show me they're really confident and that they are using it appropriately, because inappropriate use leads to inappropriate dosing and symptoms can ensue. The patients also will come in and say, you know, I took the patch, but it didn't work because I still smoked. So a lot of times it's just clarifying expectations and keeping clear communication and saying, you know, none of these medications are supposed to make anybody quit. They're really just a tool to help you through. So don't expect to put the patch on and just be able to quit smoking, because you have to kind of make an effort too. So the medicine can't make you do anything, but it can certainly help if you're trying to do something. A lot of times patients will say, I don't want to use X medicine, you know, patch or otherwise, because I don't want to put chemicals in my body and I don't want to get addicted to the patch. So there's a lot of teaching that needs to be done at times about the chemical components in a cigarette and the thousands of chemicals they're inhaling in the smoke versus the one chemical, which is nicotine, that they're getting in a patch or gum, which is definitely much safer for them. And reviewing the rationale and why we use nicotine replacement. So this is a stepping stone. This is not meant to be a lifelong patch. This is meant to be a patch that we're going to taper you down on with hopes to get you away from nicotine entirely. And ensuring the patients that these products can really significantly improve their success rates. And that's really an important part of why we do use medications. So in terms of arranging, the guideline says preferably follow up within a week following the quit date, but not everybody's ready to set a quit date, and healthcare is an expensive arena. So I have too many visits, I have too many co-pays, I can't come back that soon, or I don't have a ride. So think of other ways you can follow up. So calling the patient to check in, using your electronic medical record. So here at the U of R, we utilize what we call MyChart, and the patients can send us messages to update us, ask questions, which is a really nice, you know, secure, HIPAA compliant way to speak to patients. Other ways you can consider as well is following up through telehealth, which is kind of a new and upcoming thing that we are starting to engage in as well. So some common responses I get at follow-ups: I failed, I'm still smoking, I'm not doing well. So it's really about kind of flipping the script again and helping the patient realize all the progress they've made. So you went 2 whole weeks without smoking. You are still working on this. You're still coming in for appointments. You haven't given up yet. That's a big deal. A lot of people do give up. So when patients are still continuing to engage, that's a big deal. A lot of times I'll kind of feel like I'm a cheerleader for these people, because I am really finding just every little amazing thing they've done throughout the time we're working together and kind of shine a light on it for them so that they can walk out feeling better. So a lot of times it's just saying, you know, it's not that we haven't failed, it's just that we haven't reached your goals yet. So we really need to do that. So approaching slip-ups, when the patient comes back, sometimes they'll tell you, well, I quit and I did really well for 2 weeks, but then my friend passed away, so I had just 1. So it's about kind of educating them and letting them know what a slip is. So a slip is much different than a relapse. So in clinic, we kind of have the saying, let the slip slide. So it's about saying, okay, it happened, acknowledge it, but you didn't go back to your old smoking patterns, you didn't relapse, and you're doing really well. So you've got to congratulate them and have them not focus on that negative moment, because it happened and there's no changing it, but let's move forward. About relapse, so a slip we kind of define as an isolated or single use of tobacco, but a relapse is returning to regular patterns and use after quitting for a period of time. So it's about helping them strategize and find out what happened for this relapse. How can we help them anticipate their triggers? So if it was a certain situation that prompted them to return to smoking, how would they deal with that situation moving forward without turning to the cigarettes? Pharmacological support, so maybe their medication is not adequate anymore. Maybe we need to switch up the game with that. Patients who relapse often feel negative feelings of shame, guilt, and blame, and they blame themselves quite a bit. So it's again about kind of being that positive for them and congratulating them, saying, oh, you quit for 2 weeks, you did it, so you can do it again. And what did they learn from the quit attempt? What worked really well when those 2 weeks of smoke-free were happening, and what happened when it kind of fell apart, so that we can start a new plan and help it to work this time. Offer alternative resources. So when I meet a patient for the first time, I give them all of these different resources. And depending on what their interest is. You know, sometimes they're not technologically savvy and they don't necessarily want to do a smartphone app or go on a website or use social media. So I do give a lot of handouts and pamphlets as well for people that are kind of more amenable to having something in their hands to look at. But I do provide the quit line number for all my patients. I discuss if they're an employee of an organization locally that, you know, has employee programs. I, you know, would encourage them to utilize every resource they're able to that they feel like would be helpful to them. And then ongoing support, so reassuring them that they're here no matter what. If relapse occurs, they can call. They don't need to be afraid. A lot of times people are very ashamed and they don't want to let you know that they didn't succeed because they feel that they failed. And ultimately, that's a huge barrier to get them back in. So when we first meet and as we go forward, I try to just keep that rapport and that line of communication open so that they know when and if this happens, they're free to come back and I'm not gonna scold them or yell at them. I sometimes will tell people that we'll start with plan A and we may end up with plan B and plan C, and then we may end up doing A plus C, and then we may end up getting all the way to like M or N or O or P. It's really a difficult process to find the right fit for some people. So as we move forward, we modify and we try to do the best we can do, but we'll help them try again. It doesn't matter when it is. And I've had people take a break from the program and come back a year or so later and give it another shot. So we're happy to do that. For people that are not willing to quit, it's about kind of talking about the 5 R's, and I don't want to belabor this, but really about, you know, just trying to engage in a little bit of conversation about it and not saying, you know, the patient, are you willing to quit? And they say no, and then you just say, okay, and you let it go. It's important to try to engage in some conversation to kind of help them to start thinking about it, because they may deep down want to try, but just feel like right now it's not a great time. And then repeating every time. Sometimes we feel like we've said these same conversations to the same people over and over. You know, you definitely should quit. And they're like, nope. And then they come back the next time and the same conversation is deja vu. But you never know out of 1,000 times which one is going to be the one where the patient just decides, I'm going to do this. I got this. I also try to do some teaching with families and friends, especially ones that come in the room with the patient, because people can be very rude and judgy to their loved ones without meaning to come from a negative place, but they really do want to help. It just doesn't always come out the right way. So it's important to help, you know, halt those conversations when they're happening, if they're happening right in front of you, to say, okay, we're not about, you know, nagging or judging. We're going to help now, and we're going to support them the most that we can. So about being positive and encouraging. If someone tells me their spouse is always nagging them about it, I actually send them home with a piece of paper that has kind of these little tips and tricks on it so they can provide it to their family who may be kind of at risk to give these negative teaching points here. So in terms of having the conversation, you definitely don't want to have the conversation in the hall on the way to checkout or in front of others, because sometimes people are super embarrassed, and sometimes they don't even, like I've had patients who their family doesn't even know they smoke. They may know deep down, but the patient doesn't think that they know, so they are not willing to talk about smoking in front of their family. So it's about making sure you do it in a, you know, private setting. And do not make it feel like it's an unimportant thing, you know, by having it kind of, oh, at the checkout, oh, you're still smoking, we should talk about this. Having a really focused conversation, having good eye contact, good body language, not rushing it, not being confrontational, and not using a frustrated tone of voice is really important. And I tell my patients, for everything involved surrounding this, really timing is everything. So when it comes to talking and referring and following up, it's really, there's a lot to say about timing. So consider in your, you know, clinic or workplace having a person who's a tobacco treatment champion, and this person can be the go-to in your office who can help take the lead and educate others around them, and really maybe even help out. So if you're a provider and you have a tobacco treatment champion nurse in your office and the patient really wants to work on this, but you kind of have like double booked clinic all afternoon and you can't take the time to say, okay, I'm just going to go get our tobacco treatment champion and she's going to come on in and, you know, go over everything with you. So that can be a really good help to you as a clinician to keep your clinic moving forward, but also keep your patients supported. And they may be able to do some follow-ups and call patients for you to keep track of people in the interim between visits. So just kind of like a closing thought, we live in a really fast-paced world where we're expected to do a lot more in shorter periods of time. I'm really fortunate to have the ability to spend an entire dedicated visit with my patients to address these issues, which is definitely not typical, and I wish that was not true, but it's definitely a unique clinic that I have. But being that we do have dedicated clinics for various specialties in diseases, I would like there to be more dedicated clinics to help address tobacco treatment because it is preventable disease management, and it's very critical in our healthcare setting today. So with that.
Patty, thank you very much.
You're
At
welcome.
this time, we'll take audience questions. And please, if you do have a question, please send it to everyone who's logged in so all the viewers can see your questions. And Patty will be happy to answer them. And Patty, I have a question for you. If a clinician out there has a specific question about how to deal with a certain patient, could they get in touch with you?
Yeah, absolutely.
And bounce ideas off of you?
My email's right there on that last slide. So you definitely can just reach out and I'm happy to help. You know, certainly this is kind of my niche, so I feel very comfortable in it. And I'm more than happy to help others who may just not have the exact right details worked out.
Very good.
Okay.
Thank you very much.
Yep.